Quadcast Nation, we have a game changer. We have somebody that is helping transform the lens of healthcare. We got Dr. Faisel Syed, the National Director of Primary Care for ChenMed. Welcome to the show, my friend.
Oh, it's so good to be here. I'm very excited about this.
Absolutely. So, Faisel, I think the best way to start off is your story, like how you landed with ChenMed, because I find this is a bit fascinating. Like it's not necessarily intuitive how you landed with the company.
Yeah, I trained at an unopposed family medicine residency program in Columbus, Georgia. I always knew that I wanted to be a community health doctor, someone who works with underserved populations, people who typically had little to no access to primary care. And so after I completed my residency training, I joined a very large community health center in Tampa, Florida, in Hillsborough County. At that time, Hillsborough County had some of the worst maternal mortality rates in the United States. I mean, it was worse than many third world countries. And it was just basic stuff. I mean, just not these young mothers not having access to someone just to put their hands on their belly, basic medical attention. And so that drew me to Florida. And but while I was at the community health world, and I got into, I was a physician there. I became the chief medical officer, one of the largest community health centers in the country. When I joined, my focus was, hey, how can we increase access to primary care? And then I get into that space and I realized, well, it's not just about increasing access, but also making sure that the care that we give is effective. So in the community health space, we're desperate. We're short-staffed, short-funded. You try to do as much as you can with just maybe 1 or 2 visits per patient per year. And so that works for many people. The average American's age is still 37, 38. When we talk about medically complex seniors, people over the age of 65, we're talking about 45 million people, roughly 15% of the American population. So for the average American who's 37, 38 years old, going to the doctor or going to primary care once or twice a year, that's okay. It'll work. But for somebody now who has multiple chronic medical conditions at the same time, 5 or more chronic medical conditions, plus all the issues of living on a fixed income, where you're worried about where you live, who you live with, what you eat, when you eat, transportation issues, for example, then, you need something more than just basic access. Then you need something a little bit more holistic. And so it was while I was at the community health center that I was at one of our conferences here in Florida. And at that conference, I saw the ChenMed booth. And it was while I was there and I saw the ChenMed booth there and I thought, oh my gosh, I saw this sign, I saw this face, this name. There were vans in Tampa with that name, and they were picking up patients from our neighborhoods that I would beg doctors, please work 1 day a month. Can you volunteer? and then here there was these vans going into neighborhoods that historically doctors wouldn't go into, picking up patients, providing transportation for them, feeding them, having socials with karaoke and doing Bible study and doing all these wonderful things. I thought, how in the world is that even possible? And then so within a few weeks of even noticing that, I ran into ChenMed at a conference. And it was there, I met with someone. I was there trying to recruit a doctor for my community health center. And then I started a conversation with ChenMed, and it was just an unbelievable I like to call it was a kismet moment for me in my life, where the recruiter who was there said, "Hey, we're focused on the same neighborhoods as the community health centers, except our focus is with underserved seniors." So in the community health space, we like to think that, we're looking after the most vulnerable, underserved patient population, which we do in community health. But out of the entire community health population, if you think about the ones who are the most vulnerable, it's medically complex seniors who are living on fixed incomes. And so that's how I met ChenMed. It was at a conference, and then from there I had I had questions, because ChenMed doesn't bill. ChenMed takes full financial risk, which is very rare in healthcare delivery. Most of healthcare delivery in the United States, it's a billing model. It's a billing system. It's a fee for service system. You have a visit with the doctor, and there's a billing code attached to that interaction, depending on the level of complexity of the documentation and the length of time spent on the visit. And so at ChenMed, ChenMed didn't operate within that model. The goal at ChenMed isn't to bill more. And I just thought, well, how is that possible? that you have a physician-led group basically taking on all the responsibility for total cost of care, paying for all the hospitalizations, paying for every medication, all the doctors with every emergency room visit. Like, how is that possible? How do you make money in something like that? Especially when you're dealing with all the social issues that we deal with in the community health space. And so I started having conversations with physician leaders at ChenMed, and before I knew it, I found myself leaving the community health world and joining ChenMed as a full risk primary care doctor. That's how I started my career at ChenMed.
Wow. And so you legit saw some of the true challenges out in the community, like what you were describing, even that maternal fetal health, which honestly breaks your heart when you think about it. Like, the access to care was a true issue.
Absolutely. If for most people who, if you cannot afford, so if you zoom out for a second and you look at, okay, we got a population of 330 million people. So out of 330 million people, currently right now in the United States, there's still about 30 million people who don't have health insurance. They don't have any health insurance. Then outside of that, you have people who have health insurance, but they can't afford their copays or deductibles. That's another 40 to 60 million Americans on top of that. So if you either don't have insurance or you can't afford your copays or deductibles, then suddenly you have to make very real decisions about the cost of care. Is it worth my time to take off of work to go see the doctor? So if we don't see it or if we don't feel it, we just continue on in our lives. And so medically, let's say if you pick on something like high blood pressure, hypertension. So we know that cardiovascular disease affects over 140 million Americans, right? And over 80% of that is fueled by hypertension. Hypertension is a huge driver of cardiovascular disease in the United States. But here's the thing, 95% of hypertension has no symptoms. That's why they call it the silent killer. So for most people, we're going on in our life, think about our typical lives in the United States. We're just going, right? If it's something, I will wait until, if it's not impacting me, I'll take something, give me some quick pill or give me something quick so I can keep on moving in my life. I don't have time to slow down in my life. What's the saying go in the United States? That when you're young, you sacrifice your health for wealth. And then when you become old, you sacrifice all that. Oh, you sacrifice all that wealth for health.
Yeah. No, it really is a great point that a lot of people, despite whether you have insurance, can't afford the co-payments or what have you, or a significant proportion of the population does not have insurance. They're stuck with some really tough decisions. And as you mentioned, when it comes to some of our most common ailments, like the silent killer, as you mentioned, hypertension, a lot of people aren't seeking medical attention. So when you look at that, and then you look at what ChenMed is doing, like, how are they achieving this? Like, walk me through. Like, you did paint an excellent picture of kind of the care that they're providing and so forth, but how are you guys able to make this magic happen?
Well, basically, ChenMed is transforming healthcare for underserved seniors. So it's a very focused population where we're putting our attention. If you zoom out again, like to that number, when we think about seniors, we have 45 million plus around 45 million seniors in the United States. So far as community health centers are concerned, about 30 million Americans get their medical care from one of these community health centers. There are like 1,500 community health centers all across the country. And 10 million of those 30 million people who go to community health centers are seniors. So if you look at all 45 million seniors across the United States, there are about 10 million of them who are getting their medical care through a community health center. And so ChenMed is focused on those underserved seniors. And most of the health centers, most of healthcare delivery is that billing model that I talked about earlier, right? ChenMed is not like that. ChenMed is what's called fully capitated, meaning we pay for everything. If the cost of care is expensive, it's on us. If it's complicated, it's on us. And our average patient is over 70 years old with 5 or more chronic medical conditions. Very different population. It's a very focused population. It's very different looking after a 70-year-old versus a 35-year-old.
Mm-hmm. And what kind of, like, how comprehensive is the care? Like, say if they need physiotherapy, they need speech language pathology. Like, is there areas that aren't being addressed when it comes to a comprehensive approach?
We pay for everything.
Wow.
So through the Medicare Advantage program, see, we have the full risk contracts through Medicare Advantage. And then what that does is that gives us the flexibility to basically meet our patients' needs where the need exists. Mm-hmm. And we do this by basically what you do is you turn everything on its head. Suddenly, primary care is the hub of the wheel, instead of the language of, primary care being the tip of the sphere. There's a lot of language, primary care is the tip. We're like, no, primary care is more of the hub of the wheel. And, so when you're the hub of the wheel, then the entire healthcare delivery model, it revolves around the doctor-patient relationship. You see, in the billing model, in the fee-for-service model, the doctor-patient relationship has become very transactional. People feel it. When you're a patient in the billing model, you very much feel it. Your insurance, your copay, you're constantly talking about money and how much this will cost and how much that will cost. The intimacy of the doctor-patient relationship goes away. Like with any relationship, as soon as a relationship becomes transactional, even banks have figured out a way, like the most transactional, right, when you're doing banking. But even banking has become a nice experience when you go to the bank. I mean, there are all these people, they try to make it feel like, hey, they want your experience to be a nice experience, even though they're dealing with mostly transactions. But with something as intimate as our health, that should not feel transactional. We shouldn't apply the laws of supply and demand with our health. Like, oh, this person is in need of medical attention. Now we can make money. So the fee-for-service healthcare delivery system, it is a chief complaint system, meaning that a patient has to present with a chief complaint. And that, that works when patients are coming saying, hey, I have a problem, and the doctor just can address that individual problem. But that does not work so far as prevention is concerned. That doesn't concern, like, where's the incentive for me I'm 43 years old now, and where does the incentive come for me? And I don't take any medications. So where does the incentive come for me to go for a regular checkup if I feel fine? I feel fine, I feel good. Where's the incentive for me to take the time out to block a morning so I can go get my routine checkup? It makes much more sense for me to wait till there's some issue that comes up that I'll go end up seeking medical attention. And for most people, it's functional. Is it ideal? No, but it's functional. But when you're talking about medically underserved, complex seniors, suddenly now it's a much more bigger deal, because small things that you can't prevent or nip in the bud, they can have disastrous consequences very quickly. I don't know, have you ever been to the emergency room? Have you ever had to go to the emergency room?
Me personally, we don't know this about me yet, but I'm ICU doc. So like I want to piggyback with something you said, though. Like, what I really love the idea of addressing people from a preventative standpoint, because when you think about it, by the time, like as an ICU doc, for example, by the time they come to us, especially at that demographic, it's too late. Like your life is not going to be the same. You're not going to be at your same baseline if you survive. But if you have that access to address things early on or in a preventative fashion, man, the downstream implications can be so tremendous. Like you really are looking at preventing yourself from needing acute care, preventing yourself from needing ICU, and then also from a soft spot for me, hearing that you're hitting up the underserved, often racialized communities is something that, as healthcare providers, we need to do more of. And so I am loving everything that you're mentioning here.
Well, it's good to know now that I'm talking with an ICU doctor.
Absolutely.
So, that somewhere, everyone talks to people outside of the United States say, oh, we'd love to have your problems. 1 million doctors for 330 million people, 1 doctor for every 300 or so Americans. What a great problem to have. And you're always complaining that you don't have enough doctors. And then we have to tell them, but here's the thing. We only have about 97,000 board certified family physicians. We're split 90-10 the wrong way so far as primary care is concerned. So then what ends up happening? Primary care ends up being delivered by all the wrong people in all the wrong places. So you end up having a very limited scope primary care. Most people, when most people think of primary care, they think of 3 things. Hey, referral renewals to the specialists, refill the medications, and if you're lucky, wellness visits. That's it. Primary care doctors are called providers. Same as the doctors, as the nurse practitioners, same, all called providers. They're essentially providing the same level of care. In most of the fee-for-service environments, they have thousands of patients. They're seeing many, many people every day. The goal is a productivity. How many patients are seen every day? And how much RVUs are you generating every day? And that's what happens when you have a hospital-based healthcare delivery system like what we have in the United States. The United States has a hospital-based healthcare delivery system where hospitals now own 70, 80% of all the outpatient facilities across the country. That wasn't the case 40 years ago. It started happening in the late 80s, early 90s. I don't think anybody thought that it would end up becoming what it has become today. And so you end up having, if a patient has a simple, let's pick on a joint issue, I don't know, like a knee pain, for example. If the doctor is busy seeing 25, 30 plus people every day, what time does a primary care doctor have to do a comprehensive knee exam? It's much easier to just put in the referral, go to the orthopedic surgeon. Or if you're lucky, you can get maybe a knee x-ray. I don't know. It's done in a manner that's completely inefficient. So then the orthopedic surgeon ends up doing the primary care evaluation of the knee pain at the orthopedic surgeon rate. But if you're in an RVU-based system and the hospitals own 70 to 80% of the practices, where would you want the RVUs generated? You'd rather have the RVUs generated by when primary care is being done by the specialists, even the non-interventionalists. You know, we're trained to do all of these things, and then you get out into the world and it's like, no, we don't want, you have to refer this, you don't have time to do it, so you refer it. And then everybody complains that primary care is not doing enough. Wow. And then if they're not being done by the specialists, where else is primary care being done today? Primary care is being done in urgent care centers. Yeah, go to the urgent care, and then you can generate more RVUs. Now they have standalone emergency rooms. These emergency rooms are not even attached to the hospital, but they can bill in emergency room rates. I don't know if you have that where you are. Which part of the country are you in?
We're in Canada. So we much different world, my friend. But and what does RVU stand for?
Relative value unit.
Right.
So it is a language of billing in the United States. The more RVUs you generate, the more billing codes you generate, the more revenue, more profit. It's a billing system. The United States healthcare delivery system is mostly fee for service. We don't operate within that system. You know, we operate in the fully capitated or full risk value-based care model. And so the goal for us is not to bill more. You know, the goal for us is to actually improve health. See, if care delivery is more efficient, right? So say in the hospital-based system, if primary care, let's say pneumonia, somebody, a hemodynamically stable person has pneumonia, like me. I had pneumonia, what is it now, 2023? I had pneumonia in 2018. And I went to one of these standalone emergency rooms. So I went over there and I had the usual, you know, the workup for, I was short of breath. I couldn't catch my breath. Horrible fever, 106, 104 fever, very sick. I go to them and I had a left lower lobe pneumonia. So I had chest x-ray, I had Tylenol, I had Rocephin, I had azithromycin, I had an EKG, and I had an IV fluid. Do you know how much the bill was for that? Those couple hours for that treatment?
I don't even want to guess. You $10,000?
$10,000.
Jesus.
Okay.
Christ.
At the emergency room. That's how much it costs for pneumonia to get it treated for those things. And my insurance ended up paying like $7,000. They settled, paid like $7,000 for that, for those couple hours. So when I got the bill, you know, the summary of what the insurance paid and all that stuff, I took that bill to one of our clinics because we do all of that in the outpatient setting, in our primary care setting, right? For our patients don't feel well, we'll give them the IV. We have the X-ray there. You know, we have Rocephin in the centers. We have azithromycin. We have the Tylenol. So I went through and I asked my office manager, and she went through and gave me an itemized breakdown of how much it would cost. And she said, "Oh, you know, Dr. Syed, the Tylenol is not even a penny. Tylenol is cheap. Azithromycin is like 40 cents. Rocephin is like 80 cents. The IV fluid is like $1." She said, "For us, it's like $7. The cash price for a 2-view chest X-ray, we don't charge for that because we do that in-house. But if we sent it around our city in Tampa, it's about $15 for the cost for a 2-view chest X-ray." So of course, the cost of treating the pneumonia changes where you're getting the treatment. So by doing it in primary care, it's much more affordable, right?
Wow. Like that final tally, outpatient versus emerge, significant. And I mean, and this is more of a problem in in Canada, I would imagine, than in the States, but we also think about the strain you're putting on the emergency rooms. Like our emergency room wait times often are significant. So if you had an issue that you could normally see in a primary care, that can directly impact the flow in terms of acute care. So
Of course.
tremendous.
And for patients, it's terrible. If you have to go to the hospital, nobody wants to go to the hospital.
Yeah.
But if you have to go to the hospital and you have to see random people, you're seeing random nurses, random doctors, nobody wants to go to the hospital. I'd much rather go to my primary care doctor to get, somebody, the person who knows me the best, the staff who knows me, the front desk, they know me, the clinical support staff, they know who I am. So you can imagine in a model that is focused on improving health and delivering care much more efficiently, like real, true, high value, high quality primary care, the waste in the healthcare delivery system is not because of, primary care doctors not seeing enough of patients. The waste is because, we have unnecessary hospitalizations, which is fueled by unnecessary emergency room visits, which is fueled by this 90-10 wrong split we have in the country so far as primary care is concerned. So we got to transition away from this hospital-based healthcare delivery system to one that is based on high quality primary care. And so up until very recently, I mean, if you look at the waste has been well documented for years. I remember I first read about waste in the healthcare delivery system when we crossed the $700 billion mark with waste in the United States. That was back in 2007, 2008.
And when you mean waste, do you mean like financial waste? Is that like when you...
Well, it's all waste, right? Medical care that's not necessary.
Yeah.
Medical care that is unnecessary. So I remember, so because we pay for everything, right? We're fully responsible. So I remember thinking, when I started thinking of waste, I thought of things like, unnecessary specialty referrals, right? Overprescribing of brand name drugs when you have perfectly fine generic equivalents available, you're overprescribing brand name drugs. But those are not the main drivers of waste. They're actually very, very distant second and third driver. The main driver of waste is what I told you. It's the unnecessary hospitalizations fueled by unnecessary emergency room visits when primary care is delivered in all the wrong places. And that's what drives waste. So if you can reduce unnecessary hospitalizations, if you can reduce unnecessary emergency rooms, why do you think all these standalone emergency rooms are popping up all over the place? You think that they would be popping up all over the place if most of the patients going to the emergency room are hemodynamically unstable?
Yeah.
They have a term for that. Fast track. Hemodynamically stable people seeking medical care in the emergency room setting for whatever reason. And they're fast track. And they get billed at the emergency room rates. That's what happens. And you can afford to do that when the average American's age is only 37 or 38. Right? But now we have a growing number of seniors. And we also have had the cultural shift from where we were 40 years ago. So far as primary care doctors and independent practices versus having this hospital system, hospital-run practices and, employed physicians and all of the changes that have come as well. A lot has changed, of course, over the last 40 years, right? And so now we're at a point right now saying, oh my gosh, we now spend over $4 trillion on healthcare in the United States. We spend more money on healthcare, but you know what the entire GDP of Russia is?
No. Same as that, 4 trillion.
Less than half.
Wow.
What we spend on healthcare for 330 million people, with the average American age only being 37, 38, is more than two Russia's entire GDPs. And that includes everything. Their space program, their education, their entire economy, their war machine, their military, everything, their entire economy. What we spend on healthcare is more than double their entire economy. Just to put things in perspective. Because in America, we start talking about big numbers like monopoly money, right? But let's put some perspective for God's. And we don't have the health outcomes. You would think with all the money that we spend that we'd have highest quality health outcomes, great life expectancy, for example, great access to medical care. No, we don't have that.
This is the argument for ChenMed, right? It's the idea that you traditionally in the United States of America invested significant amounts in healthcare. Yet when you look at, for example, infant mortality numbers, other health outcome metrics, it's not number one. And so this is why I get excited about talking about these ideas of why we need to focus on prevention, as you guys are doing.
When you said it, you said we're not number one in healthcare. You're absolutely right. You know what we're number one in?
What's that?
We're number one in sick care.
Yeah.
People come from around the world to America to seek the best doctors for the most complicated situations. We're very good at sick care, if you can afford it. Yeah. If you can afford it. But if you can't, then, and the system is a system where if the doctor listens to a heartbeat, doctor gets paid, doctor orders a test, doctor gets paid. Prevention is not a goal. So the choice that we offer is a much more inspirational one, especially for clinicians. Because for us, if you think about what drove us through medical school, right? It was that intimacy, that sacred with that doctor-patient relationship. The goal should be to earn trust, build trust in order to help be better at influencing patients to making better decisions. And that could be with anything, with screenings, vaccine, diet, whatever. The doctors and the healthcare delivery system become more coaches for patients with complex medical situations rather than consultants that you just call in periodically to just, hey, address this thing here right now. No, it's a much more holistic view of each individual patient's total care, not just from when they're sick. So you have to make it very simple. So when the goal is, people will say, well, your goal is to just save money. We've seen this before. You just keep the patients from seeing the specialist, right? They miss the big point. The main driver of waste is not unnecessary specialty referrals. Of course, that is wasteful. But if I restricted a necessary specialty referral, what would happen to the patient? They'll end up in your ICU. That's what happened. They'll end up in the emergency room, not in the ICU per se. Of course, it's rare to go down that path. But they'll end up in the hospital if they get sick. If they needed to see a specialist, and now they don't see a specialist, they get sick and they end up in the hospital. So the goal is not, hey, reducing unnecessary specialty referrals. The goal is making sure that primary care is delivered in the right places, at the right time, by the right person. And you have everyone aligned saying, hey, we got to improve health. So then the question becomes, well, what are your focus? Like, what's the focus of the teams with improving health? Because you can look up online, there's 14 pillars of health, 8 pillars, so many different. We have it simplified to 3 pillars of health. Improving health means 3 things. Number 1, it means prevention. So with prevention, it's not a take it or leave it approach. Here's your flu shot, take it or leave it. No, it doesn't work that way. It's a conversation. So then the language of care delivery matters. How we respond to somebody who is resistant or flippant to whatever recommendation you're making, whether it's whatever, the flu shot or anything in prevention, that matters. How we respond matters more than whatever it is we're saying. We have to train doctors. We have to train our doctors to resist the urge to say 3 words so far as prevention is concerned. What's that? That's not true. Those are fighting words. If a doctor is coming to the patient saying, hey, I recommend this for prevention, I recommend this vaccine, and the patient comes back and let's say the patient is defensive, and the patient said, oh, but doctor, this, and whatever they say, if we know whatever they're saying is not true, we have to train our doctors to resist the urge to say that's not true, even though they know what the patient's saying is not true. Because guess what happens when you as a doctor says to the patient, that's not true? Suddenly, what do you think the patient's going to do?
Yeah, they're going to resist. Yeah.
Then they instantly get into the fight or flight situation, defensive. And when we switch from the prefrontal, when we switch from having a conversation to now we're fighting, then the wrong part of the brain is activated, and good luck trying to get to a better outcome. So we have to train doctors. There's an art with how to respond to patients who are resistant or flippant. And this is well studied for decades. Motivational interviewing been studied for decades. There's an art of influence. It's not just, hey, take it or leave it. No, that doesn't work. So the first pillar of health is prevention. We have to train the doctors with how to be more effective with responding to patients who are resistant or flippant. I mean, it's easy. Anybody, when a patient says yes, and we feel like we're doing a great job, I mean, what did we do? We just offered. Anybody can offer. The real challenge is helping motivate somebody to make a better choice, especially so far as prevention is concerned. So that's the first pillar of health. The second pillar of health is intervention, early intervention. The concept of preventing small problems from becoming big ones, nipping it in the bud. How do you do that? Well, right now, we were talking about the healthcare delivery system in the United States being transactional. Even the language is transactional. So if somebody shows up unscheduled to the doctor's office, what do we call them? The front desk will come back and say, hey, we've got a walk-in. Like you see at a barber shop or something like that. Oh, we got a walk-in, sign in the walk-in sheet. But if a patient shows up unscheduled, is that an inconvenience to the clinic? How dare this person show up unscheduled with their problems? I have all these scheduled patients. Scheduled patients are the priority. These sick patients are not a priority. Like life's emergencies happen on a schedule.
Exactly.
Right? I mean, that's why we became doctors and nurses in the first place, is to help people in their times of need, right? So even the language of healthcare delivery is not conducive to early intervention. If a patient shows up unscheduled, hey, we're booked. Go to the urgent care down the street. Go to the emergency room. Call 911. Patients will go from primary care offices to the hospital because there wasn't access. They didn't have time because the system is not set up that way. It's not that the doctors and the nurses weren't capable of taking care of most of what they see. If somebody is hemodynamically stable enough to go to the clinic, we don't deal with those types of situations often, where it's a life and death situation like what you see in the ICU, right? you have some time to intervene, especially if you have the medications on site, if you have the monitoring and the teams in place to be able to respond appropriately. If you had that set up, then of course. So early intervention is a big deal.
Mm-hmm.
And it's a lot easier to be that trusted person for patients with doing little things, like giving the patients our cell phone numbers. Every one of our patients has their doctor's cell phone number. And the doctors want the patients to call them. Let me know if you don't feel good, or just come.
I mean, that sounds like the pinnacle of early intervention, right?
And so
they're developing.
Yeah, so we nip it in the bud. Much more effective to do. I told you how much it costs for us to treat something crazy like a pneumonia. But think about like COPD exacerbations, for example. For most places, it doesn't matter where you are. Most of the time, we're gonna, it's gonna be like a dual-neb treatment, steroids, maybe antibiotics, maybe not, maybe oxygen, maybe not, maybe IV, maybe not. But for the most part, it's pretty much the same. The doctors have it already in their mind. They have their favorite go-to verbal orders that they give. Oh, dual-nebs, this, that. They just give it, and the staff will watch, and the doctor will move on to see the scheduled patients. Even if I'm running behind and I have 3 patients waiting to see me, do you know what the response is when I tell the patients, myself, hey, I'm sorry, I have a patient who's having a hard time breathing? Do you know what the response is every single time?
Go ahead. Yeah, like,
doctor, please, no. Go take care of that patient. You never know. Next time that could be me.
Yeah. It's like a culture almost. Like they see that you're treating people so well and with respect, and you've earned their trust. Like that's the number one thing I always teach the trainees. Like it always comes down to rapport and trust. Otherwise, that therapeutic relationship is not going to exist. So I love these pillars. I'm so curious. What's the third pillar?
Third pillar is what the role of physicians was for most of written history. If we have 5,000 years of written history, up until about 150 years ago, the role of physicians was mostly to help ease the transition from this life to the next life, which is an uncomfortable topic for most of us. And we don't like talking about dying and death. It's an uncomfortable topic for most of us in healthcare delivery. Forget about people outside, even for us within. It's uncomfortable. Most people want to die in their own bed. But sadly, most end up dying what's called an institutional death. The number is somewhere like 8 or 9 Americans out of 10 want to die in their own bed. But close to that number end up dying somewhere, an institution, whether it's a nursing home, hospital, somewhere. It's an institutional death. And the reason why, it's because that too, easing of suffering. I mean, the act of dying for most people is not the seconds before you stop breathing or the moments before the heart stops beating. It's usually a process. And so easing suffering is improving health. Easing suffering is not giving up. And there's a limit to what we can do for each individual person. Everybody has their own unique set of circumstances. We've seen it all the time. How many times we see it in the hospital, that you have 2 people with very similar situations, but because of their past medical history, their outcomes are very different. Or maybe not even the past medical history, maybe it was the past social history, that the outcomes ends up being very, very different with that particular chief complaint that brought them, to the medical system requiring some sort of intervention in the first place. And so in our world, if we're good at easing suffering, if patients get to do what they want to do, have an honorable death with dignity, surrounded by their loved ones in the peace and comfort of their own home, with the proper teams of hospice, palliative care, all of that, right? You know, that is improving health as well too. It's uncomfortable, but that is something that's actually what most of medicine was up until about 150 years ago.
Yeah, I mean, one of the most ironic studies, I don't know if you come across this one, it was about 2010. There was a study of late stage lung cancer patients. They got randomized to getting early palliative care versus standard of care. And not only did the early palliative care people get, have better symptom control and quality of life scores, but they lived longer, ironically. And I think it really comes down to when you look at things more holistically and you treat the patient as a whole, often this could be some surprising outcomes. So I really am a big believer of, all three pillars, but that piece at the end too, number 3 of end of life care and that palliative approach is essential, especially with the demographic that you're talking about.
With everyone, with every human being, it's all about these trusting relationships with the healthcare delivery system, which you don't have if it's a transactional one. If you have a relationship-based model of care delivery, then the patients and their families come to the primary care delivery system to help them make the lifestyle changes in order to achieve better health outcomes in those 3 pillars.
My friend, this is what you and ChenMed are throwing down is game changing, and it's really inspirational to think of, once again, that holistic approach, the emphasis on preventative medicine, the emphasis on reaching out to the people that need us the most, the patients that need us the most. Personally, I can't commend you enough. This has been an absolute gem of a show. How can people reach you?
Well, we've gotten active on social media in the last couple of years, and so please come visit ChenMed.com. We have a bunch of blogs and educational opportunities. There's a bunch of information there to learn about how to have a different kind of healthcare delivery system. We have monthly value-based care socials. We have monthly socials where doctors will come on in a virtual way. You can register when you go to the website. So every month we have these opportunities for people to interact live and ask questions and comment. How do you make something like this work? It's such hard work. How do you make that happen? How do you influence people? They're right. It sounds like it's easy, but it's not simple. It's hard. It is hard work. It takes time. It requires a lot of training. At my community health center, my orientation was the morning of the first day. With us, it's 4 weeks. 4 weeks of training. So a lot of training. So yeah, come visit us at ChenMed.com.
Dr. Faisel Syed, absolute pleasure. Thank you so much for joining us. That was amazing. Thank you.
It was a great conversation. Thank you so much for having me.